Hello, my name is Ernie Gamble from BSR Physical Therapy, and the title of this journal club is The Influence of Therapeutic Alliance on Patient Outcomes in Chronic Low Back Pain. Let's imagine for a second that this is your physical therapist or healthcare professional of choice. Do you really feel that the specific type of treatment is going to have an impact on the patient outcomes if you are trying to develop a relationship with this individual? Probably not. So specific medical treatments by themselves cannot account fully for the outcomes that our patients experience. The therapeutic alliance or working alliance or therapeutic relationship is pretty much the relationship between a healthcare provider and the patient in general terms. We'll define that in a second. But in the medical literature and then also in the psychological uh, professions, higher levels of therapeutic alliance have been associated with improved health outcomes. There's three components that make up the therapeutic alliance. First, it's the agreement between the therapist and the patient on treatment goals. Second, the agreement between the therapist and the patient on the specific interventions that are going to be utilized. And then the third component, a more general construct, simply the effective bond between the patient and the therapist. So in the literature, this is the three components that have been generally described to constitute a therapeutic alliance. In 2010, a systematic review by Hall et al. Investigated the therapeutic alliance within the physical therapy literature, and they found 13 studies across multiple practice settings: acute care, geriatric, traumatic brain injury, musculoskeletal physical therapy. And their conclusions were that they found a positive association with therapeutic alliance and these four factors: treatment adherence, depressive symptoms, treatment satisfaction, and physical function. So we can see that a positive therapeutic relationship can be associated with improved adherence or compliance with home exercise programs, with attendance in physical therapy, depressive symptoms, overall satisfaction with care, and then probably most important, just the overall physical functional outcome of the patient. A 2012 systematic review by Pinto et al. Looked at which communication factors correlate with some of the commonly accepted constructs of a therapeutic alliance. And those constructs were rapport, trust, communicative success, and agreement. They broke their results up into three interaction styles: a patient facilitating, patient involving, and patient supporting. So I summarized basically, what this means as it relates to a therapeutic alliance between the patient and the therapist, where the therapist is gonna ask probing and patient-centered questions towards the patient. Active listening is a strong component of involving the patient, and specifically active listening towards their specific concerns. And then probably most important is just overall providing emotional support, sensitivity, and empathy towards the patient's concerns. So hopefully by now you have a pretty good idea of what we're referring to with regards to a therapeutic alliance, and it really does relate closely with a patient-centered approach to care. And what we refer here to with this relationship between the alliance and patient-centered care is an understanding of the overall patient's illness experience. So we're not treating a joint problem, we're not treating a muscle problem, we're not treating a post-operative surgery. We're treating the patient's overall illness experience, and we need to have an understanding from their perspective of what that experience is. It involves a sharing of power and responsibility. This is not a profession where physical therapists are going to be exerting their will onto patients and getting them to do what the physical therapist feels they need to do. There needs to be a component of shared decision making and responsibility both from the therapist and the patient. As we discussed previously, caring and empathy are important aspects of a patient-centered approach. And related to that, self-awareness and sensitivity towards emotional cues. So the patient-centered approach, we would see the physical therapist picking up on some of these cues throughout treatment and addressing that and factoring that into the overall management of the patient. So again, we're simply not just treating a specific structure, a specific joint, a specific diagnosis. Um, a patient-centered approach is much larger and all more encompassing than that. So the specific study that I'd like to review was by Ferrara et al., and it was published in 2013 in the Physical Therapy Journal, titled "The Therapeutic Alliance Between Clinicians and Patients Predicts Outcome in Chronic Low Back Pain." I particularly liked this study because chronic low back pain is clearly one of the more challenging conditions that physical therapists manage in an outpatient setting. And if you look at the literature for chronic low back pain, to summarize, there's a whole bunch of treatments that have been found to be helpful, but the effect sizes of each of these treatments is relatively small, and there's no magic bullet for these patients with chronic low back pain. It seems like a little bit of everything helps a little bit. So investigating how the therapeutic alliance can impact outcomes with these patients could have the potential to improve the delivery of care for these specific patients. So the purpose of this particular study was to investigate whether the therapeutic alliance between physical therapists and patients with chronic low back pain predicts their clinical outcomes. This was a retrospective analysis from a previously published randomized clinical trial published in the journal Pain, where they looked at 3 treatment arms for patients with chronic low back pain. One group received mobilization and manipulation. Another group received specific motor control exercise, and then the third group just completed a general exercise program. The original trial included 182 patients with chronic low back pain from 18 to 80 years old. They had to have pain for at least 3 months duration, and the obvious, they excluded those subjects with signs of any serious pathology, such as infection, tumor, or other inflammatory disorders. The study took place in Australia at 3 public hospitals and included 7 experienced physical therapists. Patients had the same physical therapist throughout the episode of care, and the treatment lasted 8 weeks, and each patient underwent 12 visits with their physical therapist. The interventions again used were a general exercise approach of stretching, strengthening, and patient education, similar to a biopsychosocial approach to managing patients with chronic low back pain. And then the motor control exercise treatment arm focused on specific stabilizing muscles that are thought to control segmental movement of the lumbar region, so specific muscles such as the transverse abdominis, lumbar multifidus, the diaphragm, and then the pelvic floor musculature. And then the mobilization manipulation group just received manual therapy at the discretion of the treating PT. Um, there was no indication of whether thrust or non-thrust techniques were used more or less in this study. The outcome measures that they looked at the 8-week mark was function, the patient-specific functional scale, global perceived effect or a global rating of change, the Roland-Morris Disability Questionnaire, and then visual analog scale for pain. The Therapeutic Alliance was assessed using the Working Alliance Theory of Change Inventory, which is a self-report measure that's scored from 16 to 112, higher scores indicating a positive working alliance between the patient and the therapist. And this was assessed by a blind administrator at the second visit. So the treatment was 8 sessions, or 12 sessions over 8 weeks, and the Therapeutic Alliance was only assessed at the second visit. This slide's a little bit busy, but what I have highlighted here is the outcomes of global perceived effect, function, pain, and disability. All outcome measures demonstrated a positive relationship with a therapeutic alliance. So a positive therapeutic alliance was able to predict outcome for these 4 outcome measures in the specific population. If we look at specific treatment effect modifiers or the response to treatment, the first box up at the top where we see motor control exercise versus general exercise, and motor control exercise versus the manual therapy group. General exercise and manual therapy, the Therapeutic Alliance was shown to have a positive effect on treatment outcome, but not so for motor control exercise. And we'll talk about this a little bit more, maybe why. This next slide is pretty much a summary of the previous slide. So if we just look at Therapeutic Alliance as a predictor of outcome, so we're not looking at specific treatments, the Therapeutic Alliance was a predictor of outcome for all 4 outcome measures studied in this population. So the overall perception of the patient's improvement, the function using the patient-specific functional scale, pain, and disability. If we look at the specific treatments or treatment effect modification, the Therapeutic Alliance was more closely associated with outcomes of global perceived effect when the patient received general exercise or manual therapy compared to the motor control exercise. And we'll rationalize this a little bit later when we talk about the conclusions from this study. So we can see that the Therapeutic Alliance predicted all outcomes studied at 8 weeks in subjects receiving common PT interventions for chronic low back pain. It's generally accepted that motor control exercise, general exercise, and manual therapy are the bread and butter, what we do for patients with low back pain. There's the closest association between Therapeutic Alliance was with disability, or the Roland-Morris Disability Questionnaire. And to kind of put that in terms where maybe we can understand what this means, a higher score versus a lower score on the Watoki resulted in a 20% improvement in disability. So I think we would all agree that that's clinically meaningful. If we're able to develop a high therapeutic alliance or relationship with our patients with chronic low back pain, there's a potential for a 20% improvement in disability without consideration for the specific treatments that we're giving the patient. And then, as I mentioned in the previous couple slides, manual therapy and general exercise might be more associated with psychosocial predictors compared to motor control exercise, where we might be, and this has not been proven. This is just the author's opinions, but intuitively it makes sense to me. Where with motor control exercise approach, we're targeting specific muscles. We're attempting to recruit the transverse abdominis, fire the lumbar multifidus. So perhaps there's more physiological mechanisms at play here. But when we get down to general exercise and manual therapy, maybe patient expectation and preferences and values, and other psychosocial factors are at play here. So again, intuitively, this makes some sense to me. Some of the limitations of this study that the authors pointed out was the short-term follow-up. There's only an 8-week follow-up here, so we don't know how things played out over a year or longer. The Therapeutic Alliance was assessed at the second visit, and the reason the authors did this is they didn't want contamination from the impact of the interventions to come into play. So, they probably should have assessed it at multiple time points, but they thought if they assessed it, later in the treatment session, the episode of care, that perhaps maybe those patients that were seeing improvements in pain would report an improved therapeutic alliance compared to those that didn't. So, we'll take that for what it's worth. It was only assessed at the second visit. And then also, 24% of the patients that were enrolled in the original study did not complete the inventory, the Therapeutic Alliance inventory. So we don't know why these subjects chose not to do it. Maybe these were subjects that were less likely to develop a positive therapeutic alliance. We just don't know. And really, this study, probably leads to more questions than answers. So there needs to be further research. But at least this is a step in the right direction. The next logical step would be, which patient and therapist related factors are associated with positive therapeutic alliances. And then once we identify those factors, can these factors be altered or impacted to maximize outcomes? So the clinical bottom line here is the therapeutic alliance between therapist and patient can predict outcomes for patients with chronic low back pain. Intuitively, efforts aimed at maximizing this relationship has the potential to improve clinical outcomes. So again, the next step is how do we go about maximizing the therapeutic alliance? I think some of the previous work, the systematic reviews by Hall and Pinto, shed some light on this, the importance of communication, the importance of a patient-centered approach, the importance of continuity of care. These factors, have some face validity towards ways we can maximize the therapeutic alliance. But for me, the bottom line or the take-home point from this study is that it's not just the specific treatments that we employ. It's not how good we are with manual therapy or how smart we are with understanding anatomy and diagnosis that impacts outcomes in this population. There needs to be a relationship between the therapist and the patient to really maximize the outcome from any interventions that we employ from a physical standpoint. Please feel free to post any questions or comments below. Here's some references from the studies that I looked at. Hopefully we can get a discussion going here. Thanks.